Welcome to the coding webinar, and thank you for joining us this evening. Coding is the key to a financially viable practice. In addition, it is a legal attestation of work that was done, and it's important to get it right. The Community Practice Committee, soon to be the Community Practice section of the SVS, is committed to providing timely and relevant information for the benefit of our members. I would like to thank all involved from our committee and the Coding Committee for presenting this evening. Dr. Sunita Srivastava will be our moderator for the evening. Before we get started, I would like to turn over the microphone to our technical staff, Eric, to help you understand how best to participate in this webinar.
Thank you. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages, and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete the survey as it will help the SVS Community Practice Committee plan future web events. We are joined today by SVS Coding Committee faculty, Drs. Robert Fieser, David Hahn, Nikki Kennedy, Benjamin Lerner, Matthew Seidemann, Sunita Srivastava, and Robert Zwolak. At this time, I would like to turn the microphone over to Dr. Srivastava to begin.
Good evening. This is Sunita Srivastava. I'm the Coding and Reimbursement Committee Vice Chair. I'll be joined this evening with my co-moderator, Dr. David Hahn, who also serves as Vice Chair of the Coding and Reimbursement Committee, and we'd like to welcome you to the latest update on current E&M coding and practices and its overall impact to vascular surgery. We're going to hopefully round out the town hall that was given over the summer and some of the information on the vascular specialists that have been written by our members for the membership. So we're going to proceed with our first speaker, Dr. Robert Zwolak, who you really needs no introduction, but you may all know him as Professor of Surgery at the Dartmouth-Hitchcock Medical Center, SVS past president, and now the alternate vice chair of the AMA RUC panel. Dr. Zwolak, you have the microphone.
Thanks very much, Dr. Srivastava, and welcome everyone. The vendor had a little challenge with my slides, so I think Chantel will be projecting the slides for me, please. Wonderful, thank you. So my topic this evening is review of the development of the E&M changes, including the rationale for this entire effort. Chantel, please. So for 15 years, from 1995 to 2020, the office visits, the new office patient visits, and the established office patient visits required 3 out of 3 components. And these, the key components were history, physical examination, medical decision making, and these were things that we all had to get used to. So I have here on the left side of the slide the 5 new office visit patient codes, and ranging from 99201 to 205 from lowest to highest. And as you see, they required a history and physical exam and medical decision making. And the higher the codes, the more history. Can we please quiet the crowd? The higher the code, the more decision making it required, and the higher the code, the more history and physical documentation it required. And I think all of us found this to be a huge impediment to appropriate coding and reimbursement, but those were the game rules for 15 years, and this extends from well before electronic health records were commonly used until they were basically everywhere. And these coding rules were just overtly out of date. Next, please, Chantel. The requirements were onerous, and I'm sure most of you on the phone are familiar with them. We had to determine the extent of the history to determine which E&M code you could report. You had to have either problem-focused or expanded problem-focused or detailed or comprehensive. For those of you who have been to the SVS coding course, and Dr. Roddy and I have been there at this course many times, when the E&M codes were presented and our presenter started talking about the difference between problem-focused and expanded problem-focused, you could just see the eyes of the surgeons glazing over and trying to figure out how in the world am I supposed to sit there when I've got 20 patients in clinic and figure out if this was a detailed or a comprehensive physical exam, and do I really have to look into somebody's ears to determine whether or not they have an aortic aneurysm large enough to repair. These were kind of crazy, but that's what we lived with for all those years. Next, please. So the rationale for the code change was pretty obvious. So in July of 2018, CMS released the proposed Medicare fee schedule for 2019, and many of us had heard rumors about this, but in fact the rumors were true. CMS decided to propose to reduce the administrative burden associated with existing CPT guidelines. And in fact, CMS proposed as an alternative to these onerous 1995 and 1997 guidelines for the new and established visit codes that you could do either time or medical decision making, and you wouldn't have to bother with all this history and physical exam. Superimposed on that, and perhaps the most radical of all, CMS proposed that there would be only one payment level, regardless of what level you chose, 99201 all the way to 99215, there would be one payment level. And so they wouldn't have to do any auditing because it'd just be one payment level. And obviously it wasn't a very good payment level. So those people who routinely build very low level CPT codes might have been happy with it, but for surgeons who see complex patients, this would not have been a good idea. Chantel, next, please. So the CMS proposal was to use medical decision-making alone or time alone to identify the visit levels. And the rationale was that the electronic health record now allows us to pull in immense amount of needless information into our notes automatically, and with the sole purpose of meeting these 1995 and 1997 documentation requirements for billing. And in so doing, the truly important clinical information that you might have to offer regarding your patient can be buried and impossible to find in these giant notes. And all of us have seen this note flow. You can have a straightforward patient whose office note is 10 pages long, and you got to sift through it to figure out where the meat of the note actually is and the meaning of whoever was trying to write the note. Chantel? So every professional society responded to this proposal because it seemed kind of outrageous at the time. And SVS, for instance, said in their letter to CMS, we applaud the goal of reducing administrative burden associated with the office visit reporting requirements. The College of Surgeons, in a remarkably comprehensive letter, said, we commend CMS for considering options for physicians other than documenting using the 1995 and 1997 guidelines. We support CMS' thoughtful approach to reducing administrative burden by offering clinicians the option to use medical decision-making alone to document E&M levels, but we cannot support the proposed single payment rate. Next, please. Well, what about the AMA? Well, for the AMA, there was shock because, you know, the AMA obviously makes millions and millions of dollars every year on the CPT book and the CPT manual and writing these CPT codes. And the CMS proposal included many G codes. G is for government, and so the CMS can make G codes anytime. And the AMA thought this was sort of an existential threat to the CPT coding structure. And while they had tried between 2012 and 2014 to update the E&M codes, that effort had gone to ground and failed. And so suddenly there was a fire lit underneath AMA CPT, worried that their CPT codes would become obsolete. So they created a CPT work group to try to create some new codes and make this work through the traditional CPT system. That group met initially in 2018, August of 2018, so shortly after release of the proposed rule. Next, please. There were tons of meetings conducted. Seems like every 2 weeks there were meetings, and one of these first ones was in September. Next, please. September of 2018, so we're talking now 2.5 years ago. And I was actually requested to be a member of that group, and the little joke of it was I was not originally a member, but someone complained that the list of people you see here was terribly unbalanced in favor of medical doctors and primary care doctors. And so they added me as a balance point. I was an afterthought to this committee, but it was interesting work. Next, please. The work group established lots of recommendations, and I think that they played a key role here, and I think they did a pretty good job. The first thing that the work group decided, with lots and lots of input from specialty societies, was that both the CMS proposal for that single rate and the status quo CPT rules weren't acceptable. And while the physician's work in capturing the patient's pertinent history and performing a relevant physical exam is important and contributes to both the time and medical decision-making, these elements alone, the history and physical, should not be absolutely crucial to determine the appropriate coding level. Therefore, the work group decided to modify or recommend modification of the CPT codes, guidelines, and definitions to eliminate all these bullet points for history and physical exam as principal determinants in the code level selection. So the work group also thought that the current number of codes should serve as a starting point for discussion, and the current definition of time also seemed in need of modification. Next, please. So the work group conducted many stakeholder surveys. This is just an example of one of them, but the surveys focused on many things, including time and medical decision-making questions, because these are central to the concepts of the new code. So as an example, one of the questions was, what method of time measurement would you prefer for the code descriptors? I'm sure, all remember that the time that we're supposed to report, or we were prior to this, was the face-to-face time with a patient, and that would only count if more than 50% of your visit was spent in counseling and coordination of care. So very, very complex time calculation. So one of the questions they ask is, do you prefer to use total time or stick with this face-to-face time? And there was 70% of people, 69% of respondents said that total time was more appropriate, certainly easier to calculate, and seemed like much better option than face-to-face time with 50% counseling and coordination of care. So that one was pretty straightforward. And I actually supported that. I think, when you think about looking at CT scans and looking at outside notes and vascular studies and so on and so forth, I personally don't think that that portion of the time should be lesser valued than what you spend talking to the patient or their family. So I was pretty strongly in support of total time. Next, please. Now, so some people have asked, in fact, many people have asked, where did these total times come from? And the reality is, these were sort of set by fiat at the September 2018 meeting. One of the co-chairs of this committee came up with these times and said, so here you have 99202 to 205, the new patient, and 212 to 215 on the bottom, the established patient visits. And in the middle column, the 2018, the then 2018 typical face-to-face time and the 2018 total times, you'll see that the proposed minimum time for these visits were very close to the typical face-to-face time. So 20, 30, 45, 55 minutes was very close to the face-to-face time in the old coding structure, and the same thing with the established patient visits on the bottom. 10, 20, 30, 40 was very close to the face-to-face time of 10, 15, 25, and 40 in the pre-existing codes. And so this seemed like a liberalization of the total time, and it seemed like, in fact, it would be easier to report by time than it had been previously. And these values, they stuck, except for the two you see that were later adjusted. 20 was cut to 15, 55 for 205 was increased to 60, but they stuck throughout the entire thing. And the remarkable issue is, you know, is this evidence-based? Is there a logic for this? Was this survey-based? Nope. It was just a set of times that someone proposed and stayed through the entire system. So I guess that was a really good estimate. Next, please, Chantel. What happened next? Well, CPT actually passed the new codes, and we'll hear about them in much more detail in the subsequent presentations. And these new codes are based on medical decision-making alone, or total time alone, and the concept of having all these bullets with a history and physical exam is completely gone. The goal here is just to add the history and physical that's relevant to the patient care. The primary care specialties and the medical specialties at the RUC, where physician work values were recommended, provided survey data that the physician work of the redefined codes, the new codes, should actually increase despite CMS's stated initial goal of attempting to reduce the physician work burden. So that seemed counterintuitive, but in fact, that's what the RUC voted for, increased values for these codes. And CMS, seeing that CPT and RUC were making pretty good progress at this, CMS decided to defer the implementation of the new codes until 2021, when CPT and RUC could finish their work and their recommendations. They were making steady progress. So that's why, while they proposed it in 2018 for 2019, the actual codes for these office visits didn't become effective until January of this year. And finally, CMS happily accepted the RUC recommended increases in work RVUs despite their, again, originally stated goal of reducing physician burden with this coding proposal. Next, please, Chantel. So there's bad news and good news about this. The really bad news was that CMS refused to add the increased value of these office visits to the work RVUs of the 10 and the 90-day global services that we provide so often. So while our services are valued in the entirety by magnitude estimation, of course, they all have visits associated with them. And one would think that if the value of an office visit goes up and that a 90-day global has 2 or 3 office visits, then the work RVUs of that 90-day global should also go up. And in fact, the RUC endorsed that, but CMS said no. And so far, CMS has been entirely recalcitrant on changing that. So that's just a terrible and inappropriate disparity. On the good news side, Congress appropriated billions of extra dollars to offset what would have been a catastrophic reduction in the Medicare conversion factor caused by this increase in office visits RVUs. So next slide, please. And this is the bottom line to the conversion factor. Remember, the conversion factor is what Medicare pays for each RVU that you generate. So in 2020, the conversion factor was $36.09 per RVU. When Medicare finished their calculations and made the final proposal for the conversion factor for 21, given the enormous increase in the RVUs and dollars that would be flowing to the office visits, they said that the conversion factor should fall by 10.6% to $32.26. This would have been the lowest value of the conversion factor in well over a decade. And the only thing that saved us was, in fact, an enormous outcry from all physicians and all physician professional societies saying this is inappropriate. And on, I think, December 21st of 2020, at the very end of the legislative session, Congress saved the day for the Medicare conversion factor and increased from the CMS level, which is going to be 32.26 up to 34.89 per RVU. So instead of a 10.6% pay cut for each RVU you churn out, there would only be a 3.3% reduction when compared to 2020. So this is where a small loss looks good only when compared to what would have been a much bigger loss. Next, please. So what's next for the E&M codes? There are similar changes in the works for the inpatient codes, the inpatient care codes, the hospital visit codes, the admission codes. There are similar changes in the works for the inpatient and outpatient consultation codes, and similar changes for the emergency department codes, the ED codes. And it's almost guaranteed, at least in my mind, that the work values of these codes will continue to go up just like the office values did. And the question is then, what's going to happen to the conversion factor again? Will this budget neutrality cut, which will be almost inevitable, carve down the conversion factor again, or will Congress step up to the plate to save us for the billions of extra dollars that the increase in these inpatient and consultation codes will inevitably generate? So I think that's my last slide. Thank you very much for your attention, and I will be happy to answer questions now, or if Sunita is holding the questions to the end, we'll all be happy to answer them together. Thank you very much.
Thank you very much, Dr. Zwolak. This is David Hahn. I'm the Vice Chair of the Coding and Reimbursement Committee. Along with Dr. Srivastava, we'll be monitoring the questions from the audience. I don't see any right now, and in the interest of staying on time, actually, I think what we'll do is go ahead and roll into our next presentation. But before I do that, just want to thank Dr. Zwolak for that really incredible set of slides and discussion, a very linear capture of a series of incredibly complex moving parts that have happened over the last few years that have had a dramatic impact and will continue to have an impact as we go forward. Our next speaker is Dr. Robert Fiesor. He's an associate professor of surgery in the Division of Vascular Surgery and Endovascular Therapy at the University of Florida College of Medicine, and he will be speaking about the creation and evaluation of E&M coding changes from the perspective of this group. Dr. Fiesor.
Yeah, Dr. Hahn, thank you very much. And Dr. Zwolak, you're a tough act to follow, but that was a great setup. And I have the opportunity to talk about the sort of the granular approach, or sort of exactly what these new codes are. The E&M code revisions for 2021, focusing on office and other outpatient services. There's sort of two areas, well, three total: new patients, which is 99202 through 99205, the established patients, and I'll go over some of the things that Dr. Zwolak set up, and I'll be a little bit more detailed, and then talk a little bit at the end about some prolonged services codes, which are new. And honestly, I'm going to be interested in some of our subsequent speakers to hear how those are all assimilated into current practice. To kind of give a broad 20,000-foot overview, the changes that were effective starting January 1st of this year, as Dr. Zwolak mentioned, time alone may be used to select the appropriate level of E&M. And it's not just the face-to-face time, but it's the face-to-face and non-face-to-face. And so what does that mean? Well, basically, if you go in and review a patient's history and physical examination, and then with the patient, that counts. And then if you go back and review a CT scan, that counts. So any time that you have on the day of the evaluation dealing with the patient, it doesn't just have to be face-to-face. And I'll circle back with this. The other way, besides time alone, is you can use medical decision-making. And as we heard, it's not the tick and bullet points where you look at the ears and try to check 9 out of the 11 systems and everything. It's really about what is relevant to the patient that you're seeing. What disease processes do they have, comorbidities that are relevant to your role? rather than just checking off a whole bunch of boxes. And I like the example of you don't have to look in someone's eardrums to determine if their aneurysm is a good size to treat. And again, with medical decision making, the actual data points can be collected by another provider or not a provider, one of the office staff, and then you just review them. Obviously, that then counts. So with that as sort of an overview, one of the codes has been deleted, and I'll circle back with this, and then we'll come back to the prolonged E&M services. So again, there's two ways to code E&M now for newly established patients, either the level of medical decision making or a total time. So in turn, we'll start with the medical decision making because it's a little bit more complicated, or at least to me. And again, you're focusing on what the patient presents as, not a comprehensive examination or how much you do, but you really want to focus on what factors go into treating this patient, the number and complexity of problems addressed. It's not so much just the number of comorbidities that the patient has, but how many of them are relevant. So in the vascular surgery world, obviously most of our patients are diabetic and hypertensive, and those alone wouldn't count, except they're going to actually impact your decision algorithm and some of your decision makings. And so in that aspect, they actually do play a role in your complexity of the patient. Also, what plays a role is the amount of data that you have to review, whether it's CAT scans, ultrasounds, other operative notes from other surgeons, all that data information that you have to process. And as a clinician, it still occupies your time in treating the patient, even though it's not technically in front of the patient, but it adds to the complexity. And so all these things add up and give you a certain level of medical decision making. And then the final component is the risk of complications. How risky is the procedure? Obviously, riskier procedures with high-risk patients with multiple comorbidities who have a higher likelihood of doing poorly, that adds to the complexity of your medical decision-making. And so these are the three elements that go into whether you, to the level of medical decision-making that you pick. In general, there's 4 outcomes when you combine all those 3 elements. It can either be straightforward, low, moderate, or high. I will break these out. This sort of gets close to that bullet point, but it's a whole lot more clinically sensible to think of it rather than just a sheer number of elements of every history and physical examination. The straightforward exam, 99202, the new patient 99212, establishes really deals with one minimal self-limited or minor problem, or minimal data, or the risk of complications is pretty minimal. So it's a pretty straightforward patient, as opposed to a low complexity. And again, you need 2 of these 3 elements. A low complexity, either 2 or more self-limited minor problems, or 1 stable chronic illness, diabetes, hypertension, or 1 acute and uncomplicated illness. If you're looking at the low level MDM of, in terms of the amount of complexity of data to be reviewed, limited tests and documents, assessments, not much, or a low risk of morbidity from additional testing or, of course, treatment in the surgical world. And as you get more complex medical decision making, obviously this starts to add on itself. So moderate medical decision making would be 1 or more chronic illnesses, or 2 or more stable chronic illnesses, or 1 new problem, 1 acute illness. Moderate data complexity, you're looking at a couple different sources, talking with a couple different providers, and then moderate risk of morbidity or potential bad outcome with surgery. And then the highest level is the high MDM level, when you've got 1 or more chronic illnesses with severe exacerbation, progression to side effects from treatments, 1 or acute or chronic illness that poses a threat to life or bodily function, sounds like most vascular surgery patients, a high complexity of data that's reviewed, tests, documents, other notes, and a high risk of morbidity from additional testing or treatments. And so based on that, you can select your E&M code if you choose to use the medical decision making. And as was said previously, and I said before, the other way is to look at the total time for services. So the time seems to be a little bit more straightforward. It includes the face-to-face time that you're in front of the patient, reviewing the history and physical examination, talking to them and counseling. But it also includes if you have another healthcare provider. And one of the examples that was given by the AMA is if you work with a nurse practitioner and he or she spends 10 minutes with the patients, you spend 5 minutes together, and then 10 minutes you go back and confirm everything, that's 25 total minutes instead of 30, where each provider spent 15. So the emphasis is that the times that you record are additive but not duplicated. And I'll give you another example in a little bit. But what's included in this time? Dr. Zwolak mentioned some of this. Preparing to see the patient, again, on the day of surgery, reviewing the test, looking over the notes, looking at the CAT scan, obtaining or reviewing the history. Even if the history is separately obtained, your MA goes in and gets a history, you can review it with the patient. Your time then counts, not the MA's. Performing a medically appropriate examination. You don't have to look in the ears of everybody unless it's relevant. Counseling and educating the patient, ordering tests, referring and then communicating with other health professionals, independently interpreting tests, again, not separately reported, and then care coordination. Anything you do for the patient on the day of the encounter can count towards the time that you then get to select. So the new patient code 99201 has been deleted. The official recommendation is that if you have a patient that was a 99201, that you roll it up to 99202. I would be hard pressed to see anybody in our practices that have a 99201. But a 99202 is basically a new patient, straightforward medical decision making, and 15 to 29 minutes of total time on the day of the procedure. 99203 is detailed history and physical examination, new patient with low-level decision-making, and it corresponds to a time of 30 to 44 minutes. 204, moderate-level decision-making, 45 to 59, and then the highest is 99205. And then they're similar with established patient codes, with the 99211 being a low level where a physician or provider is not necessarily required. The straightforward is 10 to 19 minutes. The expanded low-level decision-making is 20 to 29 minutes. The moderate is 30 to 39. And then the highest level, 99215, is an established patient that requires the highest level of decision-making, highest comorbidities that are relevant, highest risk of doing poorly, and then the highest time, if you bill by time, of 40 to 54 minutes. Two brief words about prolonged services. There was a little bit of disagreement with what CPT recommended and ultimately what CMS accepted, but basically if you bill for either a comprehensive new patient 99205 or a comprehensive highest MDM level established patient but exceeds your time, you can then bill additionally, sort of an add-on code, but there's some discrepancy between CPT and CMS about when you get those extra times, but both of them are consistent that they bill in 15-minute increments. And so for instance, if you go 28 minutes over the maximum for a new patient of 74 minutes, then you bill the additional time once, not twice. But again, there's a little bit of a discrepancy in the CPT recommendations and the CMS recommendations. And then lastly, occasionally there'll be patients that need prolonged clinical time supervised by the physician but not done by the physician. And so if your staff is involved and you're supervising your staff for an additional hour or hour and a half, there's additional add-on codes that could be used. And again, I'll be interested to see how those could be incorporated into practice if necessary. That's a kind of a granular overview of the new coding and the different levels. And I think it's a huge step forward from checking the boxes and ticking off all the different elements of the previous system.
Thank you, Dr. Fieser, for that very comprehensive overview of the new E&M codes. We do have a question that I would like to throw out to you and Dr. Zwolak, and Dr. Ryan has asked, it seems that almost any procedure that we plan as vascular surgeons for our patients is going to be high risk. Is that how CMS is going to see that? Are we going to, I guess I'm extrapolating here, are we going to end up with problems, issues with having all of our patients be sort of the higher intensity and higher level codes?
I mean, I'll take a first stab at it. Except for the straightforward vein patients, I mean, it'd be hard to have any low or moderate complexity. I think most of our patients, by the criteria that are listed, would meet at least moderate, if not high, medical decision making or time if you wanted to bill for that. But I'd be interested in other folks' thoughts.
This is BZ. I agree entirely. 10 years ago, the very most common code was 99213, the middle level established office visit. And over the years, there's been a creep to the point that the 99214 was the most commonly reported established office visit with hundreds of millions of those. But these new codes, I'm completely convinced that Dr. Ryan is right, that basically any patient we see other than a simple, straightforward first-time vein patient is likely going to be high risk. And by the same token, I report lots and lots of codes by time now. When you consider looking at the CT images before the patient shows up and finishing any kind of a decent visit, my personal practice, and I predict for many people, because of the complexity issue that was just brought up and the liberalization of time, I think there's going to be a huge skew up to the 214, 204, 215, 205 codes. I think it's going to be enormous. So we'll see if time proves me right, but I do agree that almost anything we do is going to be high complexity.
Thank you, Dr. Zwolak. We're going to move on now to the next presentation. We have with us Dr. Vascular, who is an intensive surgeon at Norton Healthcare in Kentucky. And he's going to talk to us about employee and insight. Thank you, Dr. Lerner.
Thank you very much, Dr. Srivastava, and thank you for the opportunity to talk in this really fantastic forum. So I'm a member of a 6-person, and I have nothing to disclose. I'm a member of a 6-person vascular group. We're the primary provider of vascular services in the region. We have 4 hospitals, over 1,100 beds, and we have multiple outreaches throughout the region. We have 4 advanced practitioners who are allowed to practice with a significant amount of independence within a scope that we've defined within clinic. And so when these changes came around, this really was a unique opportunity to work this into practice, and I was tasked with that. We defined a couple goals. Obviously, accurately capturing the medical decision-making was one of the priorities, but this really was a very nice opportunity to streamline documentation, both to make our assessments more consistent and hopefully reduce any sort of risk we're introducing with the documentation. When you spend a lot of time with these codes, and particularly when you spend a lot of time with the definitions that CPT has provided for each code, you really do realize, and this is also in reference to the question from the audience, the complexity of the vascular patient is recognized and rewarded in this system, and that's something that everyone on this town hall can certainly appreciate. And really, one of the other things, and I'll sort of show how we try to do this, these definitions that really benefit us for the complexity of our patients really allow us to introduce and leverage those definitions into some consistency, particularly in documentation and billing. And so when we started with this. This is, hopefully everyone is familiar with this. This is Table 2 that CPT put out. This is how the medical decision making is arrived at. I passed this out, I distributed this to the group, and the general consensus was this was too hard to follow despite the significant improvement over the previous version. So the first act of incorporating this into practice was just to simplify this, and I made a bingo card. And so this is the exact same information on the previous sheet. I just made it into a card. These are laminated at our workstations, and it allows a provider to just go through and say, well, if you had a level 4 problem complexity, you had a level 5 for data review, you had a level 3 for risk, you throw out the lowest and you arrive at a 4, and that was certainly a start. And then what we ran into after that was the ability to consistently document this and the problem complexities in the record, although this was felt to be an improvement. And so we use Epic, and I'm sure many people do. And so this was relatively straightforward. This is a project that was taken on in my institution on multiple different levels, but we certainly try to do it within our practice to make our workflows better. In Epic, you create a smart list, and so you can do this for risk. We did it also for the problem complexity. I think someone has moved my slide there. I think someone is moving my slides. And so that pops up like this, and so when you're in your assessment and plan, the problem complexity then is populated, and that allows the practitioner to select it. And so once this was implemented and we had spent some time evaluating patients and using this system, I got a lot of feedback, particularly from my nurse practitioners, that while this certainly simplified their ability to do this, they were having difficulty actually arriving at which one of these problem complexity levels you would use. And I would refer them back to the definitions, but you do appreciate that, particularly for advanced practitioners or people who are practicing across different care practices, this certainly can be complicated. And you can sort of see that essentially with the chronic illness designation. There are three. There's chronic illness which is stable, there's chronic illness with exacerbation, there's chronic illness with severe exacerbation. These are all very minutely defined in the CPT manual, but some of that can be lost in the wash, and particularly when you're seeing a patient with multiple complexities. And this is not a trivial distinction, because obviously one will be bill is a level 3, one a level 4, and one a level 5. And when you actually look at the RVU values that Dr. that will be provided, talked about later, this is not insignificant. And so I spent a little time trying to solve this problem, and what we eventually came up with was an algorithmic approach to most of the problems that we're encountering in a vascular surgery clinic, and trying to at least provide some guidance for what we do. This is what I came up with and our nurse practitioners use for patients who are presented with leg swelling. I missed the day of vascular surgery school where I was made a leg swelling doctor, but everyone else went to that day, and so this is a very common referral to our practice, and we've tried to really sort of deputize our nurse practitioners to provide really quality care with obviously a lot of supervision. And so at the bottom, I have put all of the problem complexity descriptions along with the appropriate level, and so that's sort of what it all filters down to. And really, for the sake of what we see in an advanced practitioner clinic for them, there'd really be three flavors. There'd really be lipedema, lymphedema, or what we term venous edema. If the patient presents with lipedema, which is an exceedingly common referral, almost in every flavor that refers down, that's a stable chronic illness in a level 3. And so the documentation, there obviously can be some interpretation and some changes, but that's really where that will filter out. Lymphedema warrants its own workup, and so they are referred to a separate lymphedema flow sheet. And then we get to the sort of meat of this, which is one of the more common ones that we see in clinic, which would be a venous edema. When you go through the definitions, CPT spends a lot of time talking about goal. Goal is problems that are at goal are defined by the problem, and not every problem will get to goal. And so that is almost a definition of what a chronic illness is. But essentially, the first question that the provider has to answer and hopefully document is whether the edema is at goal. If that edema is at goal, well, that's a stable chronic illness, and so that's a level 3. If the suspected venous insufficiency and we need a further workup, there is a whole separate workup for that. But then the question of, is the edema not at goal? Well, then the first question then, and again, that needs to be documented, is whether the duration. So if it's a chronic, not at goal edema, that's a chronic problem with an exacerbation, and that bills as a level 4. If it's acute, there's a little more thought that goes into it, because if it's an acute, not at goal edema, the question that I really want my providers to ask is whether there's a suspicion for DVT. If there's a low suspicion for DVT, then really it comes down to the degree of disability. A low degree of disability is an acute, uncomplicated problem, which bills as a level 3. High disability would increase the complexity of the patient, and that would bill as a level 4. If the suspicion for DVT is moderate, that probably means that the patient needs additional workup, and so that would fall under an undiagnosed new problem with an uncertain prognosis. That bills as a level 4. And then the question of whether it's high. Now, if you have a high suspicion of a DVT, that carries with it a certain amount of decision-making, which may include hospitalization, anticoagulation, and other issues like that. And so those patients have an acute or chronic illness with a threat to life or function, and that would really be a level 5 and for the sake of this. And so this is something that we've distributed. We've done this sort of across many different problems. And I always tell my providers, this is a guide. Their decision-making and your clinical judgment should always override it, but this at least gives some consistency to how we're documenting things and working with it. And it's very straightforward to then work this into risk, which is obviously one of the other criteria for medical decision-making for leg swelling. The risk of complications and morbidity, there's 4. So it trickles down to either minimal, low, moderate, or high. There's really 5 flavors of what we would be doing in clinic, and based on the decision of the treatment decision by the provider, they would fall into one of these. Observation or discharge falls under a level 2, a minimal risk of morbidity from additional testing. Compression, elevation, which is obviously very common, that really falls under low, level 3. If there's imaging with follow-up, the patient has to come back. If you're going to talk to them, there's potential for something like that. That really falls under a moderate, and so that would be a level 4. And if there's any sort of surgical evaluation that has to go on, then that comes down to the patient risk factors. And again, that gets back to the audience question, because we do have, most of our patients have significant risk. If there are no patient risk factors and you're considering surgery for any sort of venous insufficiency or any other reason, that would fall under moderate risk. But like most of our patients, if there are patient risk factors and you're considering a surgical procedure, that would fall under high. And so that's just sort of an overview of a work in progress for all of us of how we are sort of integrating these issues into clinical practice. And that's all I have.
Well, thank you. Dr. Lerner. I think someone needs to go on mute. Is that better? There we go. Thank you. Thank you very much. That was a fantastic, comprehensive overview of a process that I'm sure it took a while to put together and is still a process in evolution. And getting through this, I'm sure, is really critical to maximizing the process and obviously a lot of buy-in. We did have a question in the chat that was related to the last presentation, but Ben, I'll throw it to you. Because I think this is part of the area that you've probably thought about as you incorporated. Sorry, if someone can go back on mute there. About documentation requirements for each of these levels, and do you have to break it down by the components of what you did? How much time was face-to-face? How much time was looking at the CT scans? Prior to the patient visit, or the documentation and work effort that goes into the post-visit piece. So maybe Dr. Lerner or Dr. Fieser, if one of the two of you wants to try and attack that question for us.
Sure, I'm happy to. Oh, go ahead, Bob.
I didn't see anything that would suggest that you have to break down the time. It's the total time, and that gets your number, which determines your level of unit inputting. I didn't see anything where you had to specifically document X amount of minutes doing this and Y amount of minutes doing something else.
Yeah, specifically when Dr. Levy was going through this at the CPT meeting, she was there's a lot of time spent about time and talking about that. You do not have to document each activity. You don't have to include a time. I know some electronic medical records are now including a timer. And while that may be helpful, that's not the end-all and be-all. There were a couple other points regarding time. What about the fishing trip? What about the football game? If you spend time talking to the patient about non-clinical things, technically that's not supposed to count. And then someone brought up, what if you're a slow typist? And they were very clear that lack of efficiency is not to be rewarded. I actually quoted them on that because I wrote it down because I thought they were trying to make a point. And so while your documentation can be included in total time, if you are, shall we say, if documentation is a challenge, you are supposed to adjust for what would be the average documentation time and not allow that to drive your billing.
Hi, this is Wolak. The only other addition I would make is that the only hard restriction on time that I know of is it can only be time spent on the day of the visit. So if you're not so good in clinic, like I'm not so good sometimes, and I finish my clinic notes the next day or on the weekend, and you're trying to report by time, you are not allowed to use any of that time you spend other than on the day of the visit. So it's another incentive to get your notes done on the day of the visit if you're going to report by time.
Thanks, Dr. Zwolak. We have another question. I'll toss it out to the group, and it's about the documentation that has to be provided to support medical decision making or time level that we use. And before I toss that to the panel, just another piece around the time-based billing. There's obviously a reality check there as well. And if you have a 30-patient clinic in a day and they all bill out at a 60-minute time, there's obviously not 30 hours in a day. And so there's some reality checks that need to be we need to be thoughtful around as those billing procedures move forward. So anyone want to approach that question around documentation for decision making or time level? Or maybe Ben, I'll toss it right to you. Why don't you take a stab at that?
Yeah, so I've gotten in the practice of trying, particularly for, and I didn't cover this in the talk. The amount of data analyzed is pretty straightforward, and I try and be as clear as possible. You get credit for either studies or notes reviewed. You get then credit for analysis and independent interpretation of studies, which, for just again, speaking to the reward that we receive as vascular surgeons, I don't know a single vascular surgeon who doesn't look at his or her own CT scans, doesn't look at his or own duplex studies, which brings up another point I'll get into in a second. But I dictate to the code. So when I look at my own CT scan for a aneurysm, I use their wording. I personally reviewed and interpreted the CT scan, and my interpretation is blank, and I fill it in. As far as saying, I leave it at that. I reviewed the primary care note, I reviewed the cardiology note, and I reviewed the ABIs, which are normal, and I sort of can tick that boxes that those are 3 pieces of data review. I do use the words from a complexity standpoint. I say that this is a stable chronic illness. As you can see, that I've sort of incorporated that into the smart set in Epic that we use. I think that helps the coders. I think that helps them know why I arrived at the code that I arrived at, and hopefully there's some consistency. Just getting back to my last point, if you are interpreting the data, it has to be something that wasn't separately reported, and there's been a lot of discussion about what that means. So if I personally if I interpreted and billed for a carotid duplex and then see that patient in clinic, I can't use interpretation of that duplex as a credit towards my data that was interpreted. There's been some concern about what does that mean for a group. So what if my partner interpreted it, but I'm looking at it again and now seeing the patient? And currently, I think, and Dr. Zolak can correct me, I think that's in flux, but I think currently you can say that you also separately reviewed and interpreted that study.
Bob, do you want to answer that query?
I agree. The other thing that's in flux, which is even a more trivial point, but seems to be quite controversial, is whether you order a test that's going to be done and interpreted by yourself, and that's going around and around because there's a sort of this glint of self-referral. If you get credit for ordering a test, but you're the one who's going to be doing the test and interpreting the test, that's a tiny bit of an issue. So that I think is yet to be settled. So it's a couple of minor things that are still haven't been entirely hammered out. And probably, I guess my advice is, if you're reporting that closely, none of us know yet what kind of an audit function CMS is going to do on these. And so, if you're very conservative and you're counting all your medical decision-making bullets that closely, the ordering the test and the interpreting the test, if you've actually interpreted the test and reported the vascular lab study yourself, you probably shouldn't also check that box in the medical decision making for the office visit. But that's my interpretation. That's not a formal recommendation by anybody yet.
Lots of things certainly still in flux. All right. Well, Dr. Lerner, thank you very much for that really great example of how you took all of this and implemented it with such a direct line of sight into what you are doing on a day-to-day basis. We'll move to our next talk, and if we can pull up Dr. Kennedy's slides
Your microphone has been turned on.
Dr. Kennedy's microphone has been turned on, and she is going to talk about the financial impact and a little bit about the payment issues related to E&M and in particular vascular practices. Dr. Kennedy is the Section Chief of Vascular Surgery and the Medical Informatics Officer at Henry Ford West Bloomfield Hospital. Dr. Kennedy. I'm not hearing Dr. Kennedy.
Can you hear me now, Dr. Hahn?
Yeah, there we go. Great, thank you.
Sorry, I think the automatic switch over to the microphone overrode my settings. I apologize for the delay. Again, I'm Nikki Kennedy. I'm a vascular surgeon from the Michigan area, and I'm going to attempt to follow the amazing speakers that have already been on tonight and go over some of the financial ramifications of the recent CMS changes to the EMS coding system here. So as we've discussed already during this webinar, one of the main reasons for the E&M coding update was to reduce the amount of redundant and lower utility components of the standard provider documentation during an E&M visit, or as Dr. Zwolak so commonly referred to it as note bloat. The idea was to improve documentation efficiency so that a provider could spend more time talking to a patient and coordinating care rather than sitting in front of an EMR screen. In fact, the AMA website quotes a statistic of 2 hours of documentation generated for every 1 hour a physician spends for patient care. By cutting this number down, the time and cost needed to take care of a patient should, on average, decrease. The AMA website lists the official CPT editorial panel reasons for these revisions as shown on the slide here. In addition to improving efficiency on the provider end, the idea is to also make audits easier or less necessary. Focusing on resource-based coding also lowers the likelihood that specialty payment redistribution, such as self-referral for lab or imaging services, will occur. As we know, the budget neutrality policy of CMS does not allow for overall increases in payments. In other words, if one area has an increase in payment values, this needs to be offset by payment decreases in other areas. Of note, this slide lists some of the services that have increased their payment values with this new legislation. End-stage renal disease in particular is of interest for many vascular surgeons. Most of these increases, however, have a greater impact to primary care areas. So CMS initially put out their finalized ruling regarding the E&M code changes on December 1st, 2020. In this version, non-primary specialties, including surgeons, were faced with a large reduction in reimbursement. This resulted in an outpouring of aggressive lobbying efforts by the Society for Vascular Surgery, the American College of Surgeons, and several other societies to reduce the magnitude of this drastic payment shift. As a result, CMS updated their ruling on December 21st, 2020, with what is known as the Consolidated Appropriations Act. This mitigated some of the specialty losses through a variety of factors, including a COVID stimulus payment, cuts or suspension of existing policies such as the Medicare sequestration and Medicaid disproportionate share payments, and also an adjustment of the previously proposed reduction in the physician fee schedule from December 1st. As I previously mentioned, budget neutrality acts as a cap on spending for all CMS reimbursement. If one code gets an increase in payment, another code must have a payment reduction to offset this expense. For surgeons, there's some key areas that may affect common reimbursement that may not impact our primary care colleagues quite as much. So in the next few slides, I'm just going to review in a little more detail some of these key areas that include global payments, telehealth, and the designated conversion factor. With respect to global payments, and I know this has already been discussed so far tonight, E&M visits during the specified postoperative periods have previously been bundled with other surgical reimbursements. With the new legislation, however, these visits will remain bundled with the global reimbursement fees, but the visits will not be reimbursed at the new increased E&M encounter level rates. Instead, their reimbursement values will remain at the pre-2020 rates. This is estimated to result in an overall reduction for non-primary care physician reimbursement for any specialty that performs less than 50% of their practice in a clinic setting. The American College of Surgeons and other specialty groups lobbied hard to get this ruling reversed, but as of today, CMS has elected to let this rule stand. Telehealth has been identified as a major factor in our post-COVID landscape. In 2020, many restrictions that had been placed on telehealth reimbursement were suspended as a part of the Trump COVID response. Some of these restrictions, however, have fallen back into place. One notable reversal pertains to audio-only E&M encounters. While video visits are not affected by this, any telephone-based billing encounter with the patient is no longer separately billable by Medicare. It is instead rolled into a bundle with other incidental services. One area of telehealth reimbursement that remains in place is remote supervision of residents. Changes in 2020 due to the pandemic allowed for billing of resident supervision if real-time audio and visual interaction was used. This was meant to allow training sites in non-metropolitan areas to have extended coverage. Many surgical groups were strongly opposed to this rule on the basis of patient safety. While CMS has not changed their stance on this, they did issue a formal statement, as quoted by the ACS on their website, that the supervising physician must be immediately available should a patient safety concern arise during these care situations. And finally, the CMS conversion factor changes from December 1st were reduced in severity by the Consolidated Appropriations Act from later that same month. For background, as Dr. Zwolak had mentioned, the conversion factor is simply a multiplier that CMS uses in conjunction with RVUs to calculate service or product reimbursements. Prior to the 2020 changes, this value was approximately $36.09. With the original final ruling from December 1st, this value was reduced to only $32.41. This would have created a reduction in payments to non-primary specialties of greater than 10%. Successful lobbying efforts were able to reduce this gap down to only a 3.3% reduction with the December 21st revision, resulting in a new conversion factor of $34.89. So in summary, the major financial changes that SVS should keep in mind include the 3.3% reduction in the fee schedule conversion factor, reduced reimbursement for global period E&M encounters, and restricted reimbursement for audio-only telehealth billing. Members should consider including video encounters if possible for these types of visits. And also, there may be some potential for revenue capture with resident supervision in underserved or remote areas, as long as quality standards for patient safety concerns are followed. And with that, I thank you for this time this evening.
Thank you, Dr. Kennedy. It was great to have that overview, and as we've been discussing in the group, repetition is so key in some of these areas as we try to absorb all the changes. We do have a question from the audience that I will throw out to everybody here. Dr. Yao is asking, what specific documentation do you need to provide to support the MDM or the time level, that's used for the new codes? Any takers?
So this
Well, hi,
is
it's
Nikki
BC again. Go ahead, Nikki.
Oh, no, I'm sorry, Dr. Zwolak. I was just going to say that we use Epic at Henry Ford Health System in Michigan, and our coding team has actually developed a series of smart phrases that specifically list out the different points that are considered in the charts that you've seen already. So we actually bring that smart phrase in and just do a drop-down menu and click on what pertains to what we've had in our note.
And again, the time one is even easier than that. All you need, and I have this in all my templates, is I spent 37 minutes on Mr. Jones' encounter today, period. And that's and because time does not have to be parsed by one face-to-face compared to any other thing. It's just plain old total time.
Well, to follow up on sort of the E&M thing, how is that bundled into the 90-day global bundle?
Nikki, do you want to take that one?
I can try. As I said, I think that as they talked about, we still have the actual E&M visits that occur within that global day period. That hasn't changed. And actually the reimbursement hasn't changed for them either. My interpretation was that although generalized E&M code visits have increased in the global period, anything that falls within, have increased in general, anything that falls within the global period will be at the pre-2020 rate. So we're still able to bill for it, just not as much. At least that's my interpretation.
So that's right. I guess I might say just a little bit differently that for those of you who have filled out these RUC surveys for a 90-day global for a carotid stent or carotid endarterectomy or whatever, you're asked how many visits there are. You're asked about the time you spent skin to skin. You're also asked for your global estimate of the total RVUs compared to some comparison list that is provided at the beginning of the survey. And the total RVU is determined by the RUC and by CMS based on magnitude estimation of the whole package. The argument is, though, in addition to the RVUs for the whole 90-day package, CMS records the median number of visits, both in the hospital and return visits in the office during that global period. So carotid endarterectomy, for instance, includes 2 office visits in the 90 days after the patient is discharged. And I've forgotten the details. I think maybe they're both level 3 office visits. And carotid endarterectomy 90-day global is 21 RVUs and change. Well, if the value for a 99213 office visit has gone up by 0.3 of an RVU, and there's 2 of them built into this package for the carotid endarterectomy, you and I and all of us could easily argue that the total RVUs for carotid endarterectomy, which includes 2 level 3 office visits, ought to go up by 0.6 of an RVU. And so instead of like 21.3, it should be 21.9 to represent the increase of the office visits that are inherent to that 90-day package. And the AMA RUC was strongly in favor of that. The AMA RUC completely endorsed that, but CMS decided not to do it. So that's at least that's the way I think about how surgeons kind of got short shrift in this new E&M evaluation.
Thank you so much, BZ, for that comprehensive answer. We're going to move on to our next presenter, Dr. Matthew Seiderman, who's Associate Professor of Surgery, University of Texas in San Antonio. He is also former chair of Coding and Reimbursement and now is Council Chair for Health Policy and Advocacy. And he's going to talk about the overall concern that we have as vascular surgeons, which is, how we're so frustrated by a lot of the changes and we see ourselves losing ground. How can we, as individuals, as practitioners, and as a society, promote more favorable reimbursement and coverage, and what do we need to do? I'll hand it off to you, Matthew.
Thank you, Sunita. So, thanks for that introduction. I got the tough question of how can vascular surgery promote more favorable reimbursement strategies and coverage? So thinking about that, I'm going to break that down into answering a couple of questions first, and then point out a couple of problems, and then outline, I think, 5 strategies to get us what we want. First, we'll talk about how are procedures valued, how are procedures reimbursed, and how are they covered. We'll talk a little bit about what I call the CMS feedback loop, and then go over some strategies and Q&A. So prior to 1992, payments were based on charges. And then everything changed in 1992 with the introduction of the RBRVS, or the Resource-Based Relative Value Scale, also known affectionately as fee-for-service, which is the world we're currently living in. We're also currently undergoing a conversion from fee-for-service to merit-based incentive payments and alternative payment models, the MIPS and APM, or pay for quality. The currency of the RBRVS is the RVU, the relative value unit, and the total RVUs for a procedure are a summation of the physician work RVUs, or the WRVU, the practice expense, and the professional liability insurance. The idea of the RVU is that it allows comparison of all codes across all specialties and services. So new and revised codes from the CPT panel meeting are forwarded to the AMA RVS Update Committee, also known as the RUC. In addition to new and revised codes, codes that are identified as, quote, potentially misvalued, either through RUC screens or through CMS rulemaking, are also valued. Once, or reviewed. Once codes are placed onto the agenda, they're circulated to different specialties, and every society can comment on their level of interest or their LOI regarding making recommendations on the value. Typically, the specialty who is the dominant provider of the service based on Medicare claims data will lead the evaluation and recommendation. A RUC survey is then created and sent out to society members for participation. Many of you have likely received an email from myself and my predecessors asking you to participate in a RUC survey. The RUC surveys are long and onerous, and I'll apologize for that, but they're made that way specifically by the committee, so they're fairly standardized. In general, you'll pick a similar code off a list of reference services, what we call the key reference service. You answer a bunch of questions regarding the intensity and the complexity of the code you're evaluating versus the comparison code. You answer questions about service time, including pre, intra, and post-service, and then answer questions about the visit patterns, both inpatient and outpatient office after the procedure. And finally, you'll submit what you recommend the RVU should be. Once the surveys are completed, our team will compile all the data and analyze them regarding the recommended values, service times, and visit patterns. We then create what's called a summary of recommendation, or SOR, that is written and submitted to the RUC prior to the meeting. The RUC team then presents these recommendations before the RUC and advocates on behalf of the society. The RUC then votes on the recommendations, and if they approve the recommendation, that's great for us. If the recommendation fails the vote, then we have to go to what's called facilitation, which is basically a smaller group of RUC members in our committee to try to hammer out an acceptable compromise. At the end of the meeting, the RUC finalizes all their recommendations to CMS for consideration, and the final RVUs are actually assigned by CMS during rulemaking, not by the society or the RUC. So how are procedures reimbursed? Well, that depends, okay? It depends on site of service, depends on payer, depends on coverage, et cetera. Starting with site of service, if you're doing an inpatient procedure, well, the physician is paid for by the professional fees determined by the facility total RVUs multiplied by the conversion factor multiplied by a geographic practice cost index. So payment equals RVU times CF times GPCI. The hospital gets their payment based off of the DRG for the inpatient. If you're doing your procedure as a hospital outpatient, the physician payment's the same. It's still the professional fee, total RVUs, conversion factor, GPCI. Hospital payment is different. Now it's no longer based off the DRG, but it's paid for based off the HOPS system, and it's dependent upon what APC and what level the code falls into under the HOPS system. If you're working in an ASC, again, the physician's paid for by the professional fees as determined above. The facility payment, however, is determined by a mathematical percentage of the HOPS payment, which roughly equals 60% of what the hospital gets through the HOPS payment. And finally, if you're working in your own OBL, the physician and office are paid by taking the non-facility total RVUs, not the facility total RVUs, but the non-facility total RVUs, and then multiplying by the conversion factor and the GPCI to get total payment. So how are procedures covered? Well, through Medicare, payments for Part A and B are processed by regional Medicare administrative contractors, or MACs. In the old days, every state had their own MAC. So there were certain big companies that had more than one state, but they were state by state. Then about 15 years ago or so, they started awarding regions and contracting the jurisdictions into carrier regions. And so the map you see on the screen here are the current MACs and which company currently holds that contract. So these contractors, they apply to CMS when these regions are opened, and they make a bid, and if they win the bid, they're awarded that region. We also talk about coverage policies. So initially, CMS will determine whether or not something is covered. So just kind of from a more global approach, like carotid stent without embolic protection. That was deemed right off the bat by CMS as a non-covered service, and so that is not covered anywhere in any region under any circumstance. Beyond that, we have local coverage determinations, or LCDs. These are MAC policies that determine coverage for their region. The new policies, as they're being proposed, are first reviewed by the CAC, or the Coverage Advisory Committee, and then published for comment before implementation. This is the best time to try to change an LCD that is not going to be favorable to vascular surgery, because once the comment period is closed and the LCD is implemented, they are very difficult to change unless they are reopened for comment or update. And then broader than an LCD are national coverage determinations, or NCDs. This is a policy published by CMS that overrides all the MACs and provides coverage for a particular procedure across all the Medicare payer jurisdictions. So, CMS feedback loop. In my opinion, CMS payment functions really kind of much like an endocrine feedback loop. So, if they start to spend too much money on a certain procedure, that rises to a level of attention which triggers the code or the procedure to be nominated as potentially misvalued. If a procedure is rapidly growing, say more than 100% every year for 2 years, that also triggers the code to be nominated as potentially misvalued. Codes that CMS puts in rulemaking as potentially misvalued are then triggered for review at the RUC, and they almost always require a new RUC survey to confirm the value or to establish the correct, and I'll put in parentheses, lower values, because if a code is flagged as potentially misvalued, it's likely not going to be increased, it's likely going to be decreased in value. So, what are strategies we can use for more favorable reimbursement coverage? Well, I think the most important one up front is that we need to establish appropriate values for new procedures from the start. Once a procedure has a value assigned that is inappropriately low, it is a tremendous uphill battle to try to correct that and to have the value increased. And just some of my observations from years of service at the RUC, the main crux of the RVU is that the RVU is equal to time multiplied by intensity. But too often, intensity is disregarded, and RVU is basically calculated straight from time. So it's a lot easier to measure time, and intensity can be a very relative thing. So that's why it's important for us to get these right from the start. Next, a code lives and dies by the survey. So if we have a strong survey, that will carry the day, and we can get any value we want passed as long as the survey is strong and supports it. A weak survey kills a code. It will, no matter what the code is, it will be devalued by a weak survey. Next, I would say that the RUC survey is the worst place to underestimate your time. If you're filling one of these out for us, think of your typical case. Don't think of your hardest case, the worst possible situation. Don't think of the easiest case. And definitely it's not the place to brag about how you can do a FemPop in 35 minutes. Be honest. And if you don't know your own time, ask your anesthesiologist. They'll tell you what your real time is. And then lastly, the fee schedule is more impacted by volume than RVU. So RVU changes that we had implemented for EVAR had essentially no impact on the dollars of the RVU conversion factor, whereas RVU changes for the E&M codes, even though these are small values, because the claims and the volume are so high for that, pushed the conversion factor down by 10.6% before Congress stepped in to intervene. Okay, number 2, practice appropriate use of codes. As I said in the CMS feedback loop, overutilization triggers revaluation and devaluation with reduced payments. So I think as long as all of us practice appropriately, this isn't something for us to worry about. I think the few small bad apples out there that are overutilizing different procedures or inappropriately utilizing procedures drive up utilization, which triggers reviews and devaluation. Number 3, pay attention to coverage determinations and denials. If you see anything that doesn't seem right, send it to us, especially if it's in the comment phase. So LCDs that pop up that aren't right, let us know. That's our job. We're here to fight those and work to change those. If you get asked to participate in your max CAC and you can do it, please do so and let us know that you're doing that. We're always looking for insiders and people that can give us early warning if there are coverages coming out that are going to be unfavorable to vascular surgeons. Number 4, donate to the PACT. When we were faced with an almost 11% cut for the last year, it was the action of the Government Relations Committee and the PAC donations and a lot of tireless hours put in by members of the Policy and Advocacy Committee, the Government Relations Committee, and the PAC, and members that reached out to their congressmen and said, hey, this isn't right, and that got us in front of the people where we could get legislation passed to prevent an almost 11% cut. That kind of close interaction with Congress to help us explain our issues and how this is hurtful to us and how this harms patients is what we need to be able to get the favorable legislation that we need, and that kind of access does not happen without PAC dollars. And number 5, I would say get involved. We, with the SVS Policy and Advocacy Committees, we're always looking for motivated people to join us and help us advance the care of the vascular patient. So with that, I'll stop for Q&A, and if you want to learn more, my email's there, or you can email our SVS staff, Tricia Krishak.
Thank you very much, Dr. Seidemann. A really great recap of what seems like a fairly straightforward process. I think many of us know the amount of work and complexity that goes into the process you're describing. There was a question that came up earlier from Dr. Cook. Can the speakers provide some of their smart phrases for us to adapt to our own notes? The slides will be made available, and I think we heard a couple of speakers comment that many of their smart phrases simply are lifted straight from the verbiage from the CPT manual as it relates to the requirements for medical decision making and billing. So, I think most of those are available, but certainly, for example, Dr. Lerner's really impressive algorithm that he's put together for how to manage through some of those venous patients that can have a level of complexity and lead them to the right billing code will be available as the slides. And then I see from also somebody's mentioning that Epic does have a large online library. Dr. Seidemann, if you could just comment, we've heard a couple of times the importance of the survey as it relates to evaluation at the RUC, at the RVU Update Committee. And maybe if you could just connect the dots a little bit and describe for the audience, you said a good survey is good and a bad survey can kill a code. Just how important that survey and what that data represents when you sit up in front of that group and try to explain what it is that's being done, and how much you rely on the elements of the survey and what some of those survey elements are to help you make a cogent and well-supported and bolstered argument for the appropriate valuation of codes. Maybe just connect the dots between our membership gets a survey, and then how that ends up on your plate and what you've got to do with that data to present it to the RUC.
Sure. I'm happy to answer that one. I think I'm having a little bit of audio back and forth. I think some of that echoes me, but if you can't hear me, put it in the chat. But so the survey is critical. And so what I mean by a good survey, a lot of that is how many respondents there are. So if we have a large number of members respond to a survey, that makes it stronger. The distribution of the recommendations as far as the RVUs from the people who respond to the survey is important, especially when we are doing multi-specialty surveys where it's not just vascular surgery, it's vascular surgery, it's SIR, it's interventional nephrology, it's interventional cardiology. We want to see all the responses correlate and complement each other. We don't want to see kind of a bimodal distribution where we say it takes 45 minutes to do a femoral stent, but radiology says it takes 15. That becomes problematic. So any data that that is incongruent ruins a survey. Low survey responses ruin a survey. Survey data that has times and values that are way overinflated that then make this a service, make it what we call a rank order anomaly, where it's compared within other similar procedures that are already valued in our group of codes. That invalidates a survey. And so those things make my job as the RUC advisor, the person who has to sit at the front of the table and argue for values, very difficult. My father practiced law in San Antonio for over 50 years and just had to close up shop thanks to COVID and some health problems. And I never really had any desire or intention to do law, but I have to say that kind of sitting at the RUC and arguing for vascular surgery is probably as close to a courtroom that I'd ever want to be in. And in my mind, it's kind of like if you have a strong survey, it's like you're defending and arguing for somebody who is who's innocent. Whereas if you got bad data, it's like trying to get somebody off for capital murder when they were caught red-handed at the scene.
Well, that's a great visual, I think, for us, and the hard work that you've done, that many of us have witnessed, and the folks before you, certainly Dr. Zwolak, Dr. Gary Seabrook, who have worked tirelessly for the advocacy of our specialty is duly noted. I'm going to toss it back over to Dr. Srivastava to take us out as we conclude this and to answer that last question in the chat. But I just do want to say thanks for everyone's participation, and Dr. Srivastava.
Thank you, Dr. Hahn. We have a question from Dr. Jen about the best mechanism to contact us regarding coverage issues or LCD issues in the area. So, Dr. Jen, there are several ways you can email any one of us directly. Alternatively, probably the best way to streamline the policy issues is to email us through the vascular.org website under advocacy and coding and reimbursement. There are some links to our very talented staff who keep us on track, Tricia Krishak, Mo Malik, and they often will field the questions, get them directly to the committee, and we meet on a monthly basis and come up with a plan of attack. There may be some follow-up emails with you to, again, garner some more information to the specific issue, and we will be polling our committee and members to see if there are similar geographic concerns. I'd like to thank the Community Practice Committee and Dr. Dan McDevitt for this opportunity, for such a talented group of presenters, and for our interested members who took the time out this evening to be present and to be updated on some of the upcoming changes. The talks were absolutely phenomenal. I'd also like to plug our December SVS Coding and Reimbursement workshop that will have a separate E&M workshop attached to it for those of you who would like more up-to-date information late fall and winter. You can sign up through vascular.org. There'll be more information coming. And again, great webinar, great information, and thank you for all your time and questions. Have a good night, everyone.
On behalf of Society of Vascular Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this survey, as it will help Society of Vascular Surgery plan future web events. This concludes today's program. Thank you and have a great day.